Could you talk about how recent developments in HCV treatment and screening technologies contributed to the evolution of the priorities in disease staging between the interferon era and the current treatment era?
The breakthroughs in hepatitis C treatment have had major implications on all that we do with hepatitis C, including staging. We used to stage disease principally to find out which patients would benefit from treatment. We wanted to know, because the treatments had toxicities, whether the benefits of treatment would outweigh those toxicities. And so we entered into these complicated algorithms to ascertain whether the person had enough scarring in their liver to justify the side effects and relatively low expectations for success with treatment. Now that we have medications that are more efficacious and at the same time safer, the approach to staging has changed. And we're not so much focused on justifying whether or not the toxicity of treatment is justifiable anymore. We're trying to find out if the person has cirrhosis and if treatment is therefore urgent, and if other management is necessary besides treatment, and in particular if the person needs to have periodic screening for hepatocellular carcinoma and management of portal hypertension. Persons with cirrhosis have extra risks and therefore need additional support besides simply eradicating the hepatitis C infection. So how does that change in our goal affect what we actually do? Well, now that we're not so much interested in very nuanced differentiation of whether someone's scarring is in their portal tract or expanding their portal tract or starting to bridge between portal tracts and the central lobular vein, and we're just really saying, do they have cirrhosis or not, then we're looking for tests, naturally, that are good at detecting cirrhosis. And in particular, we're interested in expanding hepatitis C treatment, and so we're looking for tests that can be used in a variety of different settings, not just in tertiary care clinics. And so there have been some blood tests and radiographic type tests developed to replace the liver biopsy, or at least to augment the liver biopsy. And we call those non-invasive because, unlike the liver biopsy, they don't require invasive procedure. And those tests happen to be pretty good at finding patients with cirrhosis and who need that alternative management pathway. And so yes, that's how the changes in treatment and the improved efficacy and improved safety of treatment have already altered our approach to staging.